got 13 letters. So he has got 13 degrees to his credit. The academic achievements are, he organized 2 state level, that is Tamil Nadu ISS CMEs successfully in 2011 and 2018. Presented around 200 research papers with 600 citations in reputed journals in anesthesia, pain and nutrition. Devised a new technique of single shot spinal cocktail for labor analgesia. Expert reviewer in many national and international journals. Received Dhanvantri Award for Medical Excellence from Honorable Minister of Panchayat Raj, Mr. Manishankar Iyer. Best Reviewer Award, Indian Journal of Anesthesia. Associate Editor for Indian Journal of Anesthesia. Editor for Editorium Journal of Anesthesia. Given many lectures in national and international conferences. His areas of interest are anesthesia, pain, epidemiology, diabetes mellitus, biotechnology, drugs. Like ChatGPT, like artificial intelligence, ChatGPT is in anesthesia, our ChatGPT.
So whenever I put anything on academics, I put a big salute to the legendary teacher of 2 centuries, Dr. Ravi Shankar. So many people, when they see the echo, they see the hero. They see the hero. Sometimes the heroes are not providing the outcomes. Sometimes these people also give the outcomes, better outcomes. That is how everyone sees the EF and nobody sees the diastolic function. Sometimes the next heroine may prove what is the outcome like. So what is the problem here? Diastolic dysfunction. Everyone sees grade 1, grade 2 in the echo report. LV does not relax properly. It gets stiffer. So when it gets stiffer, the filling of blood is difficult. Normally LV filling pressure is less than 12. Now it becomes stiffer. That is, in other words, you call it as less compliant. So you put blood, it is difficult to eat. So the pressure becomes increases. So this is less blood, stiff LV. So we need an atrial contraction, atrial systole to push more blood, because LV is stiff. Normally it cannot go through from mitral valve, through the mitral valve from LA to LV. So you need an atrial systole or a kick to push in blood into the LV. So incidence varies. Even in children they are shown, and the incidence more than 65 years, it is around 25%. What are the causes? Hypertension, aortic stenosis, hypertrophic cardiomyopathies, diabetes. These are the routine causes we are thinking about whenever we see diastolic dysfunction. Is the patient aortic stenosis? Is the patient hypertensive? Cardiomyopathy. But we are upnik about this cause. Whenever we see patients of diastolic dysfunction, we don't see or look into this cause of OSAS. Why we should know this? Okay, diastolic dysfunction, this Mysore conference, fine lecture is being organized. Why we should know this? Even in the absence of systolic dysfunction, it is an independent predictor of cardiovascular morbidity and mortality. It can proceed to heart failure with normal EF. The ejection fraction is normal, but the patient is having heart failure. This is what is called heart failure with preserved ejection fraction, or heart failure with normal EF. Now what is special in this? Relaxation starts in systole. So that is the thing about the cardiac muscle. Ventricular muscle starts to relax not there, here, starts there only. So the mitochondrial level, the relaxation starts even in systole, is number 1 point. Number 2, relaxation also needs energy. Relaxation is an active process and it also needs energy. That is why diastole is important, because it starts in systole and it needs energy. Now what is the pathophysiology? I have already told here the volume is increased, what you call as delta V by delta P or something like that. In what is the increase in pressure for an increase in volume? For example, from the LA 10 ml is going into the LV. The pressure rises by some 5 millimeters in the LV, take it. But now, if you have put in LV 10 ml only, the pressure rises by 20 millimeters. That is what it is shown here. So that means the LV is not compliant and the LV is stiff. In other words, the filling pressures are high. Now, yes, we have told ALV is stiff and the decreased ALV filling. Here we can see. And after decreased ALV filling, the atrius puts in more, all these things happen, and backward symptoms from the LA can happen. And if the filling pressure is going on high, into the aorta, it cannot push. So forward symptoms can also happen. So whenever a patient of hypertrophic cardiomyopathy comes with unexplained dyspnea, we are in, this is what is called diastolic dysfunction. Maybe going for an early diastolic failure. Decreased exercise tolerance. If the patient goes into complete right heart failure, right-sided problem, then they go for jugular venous dysfunction, edema. And if there is a forward problem, then they come up with symptom of fatigue. So unexplained dyspnea is a normal clinical feature. That is what is happening here. Other symptoms are relatively late. This is in a symptom setting of a disease. For example, he should not have interstitial lung disease. This setting should be there of aortic stenosis, hypertrophic cardiomyopathy. In this setting, unexplained dyspnea, we are going for diastolic problem. So these are the clinical symptoms. Now what are the clinical signs of diastolic dysfunction? The ECG can show a stump. You can see the stump here in the ST level. So this is a classical sign of diastolic dysfunction. And they may have left axis deviation or they may have left atrial dilatation. LAD will come to both. So they can have atrial fibrillation. The problem with atria dilatation, two problems. Atria dilates, it's prone for fibrillation. Number two, atria dilates, it's prone for thrombosis. These are the two things if you have to keep in mind whenever the atrium dilates. So these are the other clinical features when you see the ECG of left axis deviation or left atrial dilatation along with AF. Echo findings and grading. This is what is very important here. So we have a stiff LV. Atrium, then the blood has to come into the LV. So what is the flow velocity across the mitral valve? This is very important. Early diastole, it is called E. Atrial systole flow velocity is called A. So E is the flow velocity across the mitral valve in early diastole. A is atrial systole flow velocity across the mitral valve. So this is the simple thing. So E by A is more than 1 normally. So because normally everything is normal, early diastole the filling will happen. It doesn't need 20%, less than 20% only will need atrial kick to push the blood. So this is always less. So E by A is always more than 1 normally. Now you see here, the first thing, you are keeping the Doppler there exactly at the mitral inflow inlet, and you can see this is 1.01. You can see this is E and this is A. The next you can see the E by A is more than, hello? Pointer is not working. The pointer will not work in LED screens. That's another problem. So as the technology moves up, we have to increase the technology of your pointer screen also. Yes, sir? I don't have this high-tech pointers. So you can see here, E by A is less than 1. Here E by A is more than 1. E means mitral inflow flow velocity during early diastole. A means flow mitral valve flow velocity. Velocity will come as 60 centimeter per second. You can see that here, some 60 centimeter per second, 42 centimeter per second. Immediately, as soon as you keep the probe, that will show there. This is slowly automatic. When after that severe restrictive pattern means it will go again. The E by A ratio will become more than 2. This is what is normal diastolic function. Impaired relaxation slowly. This is normal. 1.01, 1.2 is a normal thing. And early is less than 1. So then we know E and A. There is one more thing, E dash and A dash. These are values similar to A and E. When you say E, it means early. When you say A, it means atrial systole. Now, where are you keeping your slash? That is the thing. If you keep a slash here between that in echo, ventricle and atrium junction, that they call it as mitral annulus inflow. So, if you keep it here and see the same E and A, LE diastole and A, then it is called E dash and A dash. So, you can see if you keep it here in the septum and then see that is septal E dash. If you keep it in the lateral wall, that is called lateral E dash. And sometimes people will do the routine E, A, and ask them to make a Valsalva maneuver. Video, Ruma? Yes. Now you can see the Valsalva maneuver, things are going like this, down. The next thing is not found only. So, if the decrease is more than 50% in Valsalva maneuver, then it is significant diastolic dysfunction. So, where are you keeping the slash? That is what is important. If you keep the slash here, then it is E. If you keep it E dash, then if you keep it here, it's septal and it is lateral. So, you can also monitor the LA volume. The computer gives. We are not going to, we just push in plus, 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 and this line and this line click, the LA volume will come, 20 ml or 15 ml per meter square. It will come as meter square. Then you have to load our height and weight of the patient. Then only it will show correctly, height and weight of the patient. Otherwise, it will be meter square. Then we have to calculate here what is the height and weight, and then, because if you say here, the monitor will show 20 ml by AL method or SIMP method. It is not big headache for us. The monitor will show AL method. Click. It will show the LA volume. If SIMP method, click, it will show the LA volume. LA volume is normally less than 20 ml per meter square body surface area. If it goes beyond 35, 34, then we are in for severe diastolic dysfunction. So, this is the grade, E by E dash. E is normal mitral inflow, early diastole. E dash is you keep in the annulus, and this thing should be more than 14. Septal E dash is less than 7 centimeter per second. Whenever we say E dash or E, it is velocity. Velocity is measured in length by time. So, centimeter by second. If the TR velocity, normally if you put in the TR velocity, it is less than 2.6. So, it is more than 2.8. LA volume index is 34 ml or more. So, what is the management? We know the diastolic dysfunction. Weight reduction, treatment of hypertension, regular physical activity, OSAS corrections. AC1 inhibitors, ARBs, beta blockers, thiazides, everything she has told, because it is very difficult to run in a passenger train after Aruna Parameswari's Vande Bharat train. So, that is a problem here. So, AC inhibitors, ARBs, beta blockers, thiazides. So, what is the basic difference between diastolic failure and systolic failure is we use calcium channel blockers also. There we use less calcium channel blockers. All the otherwise routine investigations, I will all diastolic failure, if you have doubt, increase your hemoglobin from 9 to 12. Most of your symptoms, those so-called exercise tolerance will become better. We can do electrolytes, NT-proBNP and all. So, anesthesia concerns. I am coming to the topic after 12 minutes. Was there a diastolic failure earlier? What is a person's exercise tolerance? I have seen a lot of patients. Echo will show diastolic dysfunction too. The patient, if you ask, no, the patient will tell, even I can wash my bed sheets under big towels. So, if you are able to do a bed sheet, thick leather thing, wash and keep, then it means the meds is more than 10 or something like that. So, exercise tolerance, elderly females, hypertension, obesity, renal damage. Are there any clinical signs of edema, irregular pulse, JVP, pulse pressure of more than 70, cardiac? Edema is JVP, right heart gone. Irregular pulse, AFS comes. So, all these things are danger factors. You may be cautiously looking at that. So, what are the aims and goals? You maintain the rhythm, because I have already told atrial systole is needed. Optimize preload, because something is coming, LAK, not much thing is not coming here. So, then what to do? LA itself is underfilled. So, maintain no hypovolemia, maintain heart rate, inotropes, diuretics and judicious fluid use. judicious fluid is very important. If you don't have backward symptoms, err on the higher side. Give little extra fluids. If you have backward symptoms, then wait. It will come again. Myocardial ischemic changes, hypertension, already she has told. Any sudden increase in the afterload, that is to be taken care of. It will come again. So pre-medication, adequate anxiolysis, because we don't want catecholamine surge. Nerve blocks, they have minimal hemodynamic changes. Neuraxial block, yes, this is what is the problem. Yes, we have diastolic dysfunction, great. Can we give neuraxial blockade? This is the problem even in Tanjavur conference. So neuraxial blockade, opioids. If you use opioids, it doesn't mean it is decreasing your hemodynamic problems. It is not because of that. It is because we are giving less local anesthetics. We are giving less local anesthetics. Bupivacaine come down from 2 to 1.5 ml and then add fentanyl. So you are getting less hemodynamic problems. The less hemodynamic problems is because of less drugs, local anesthetic drugs. So neuraxial blockade, we have segmental spinals, sequential spinals, epidurals, sequential epidurals. So good preload, sequential epidural, give 5 ml, wait, give 5 ml, wait, and do the LSCS or whatever it is. Good preload, maintain afterload by phenylephrine shots. The rule of 70 is pulse rate is 70, MAP is 70, pulse pressure is 70. So what do we need to do on induction? We have got opioids. That is what most people do. I don't do, or whatever. My preference is like that. I start the case, I give morphine or whatever, fentanyl, and then midazolam, and then wait for 3-4 minutes. This is what is the major problem now. So as soon as you give propofol immediately, we may need 2 milligrams or 3 milligrams. You wait for 3-4 minutes, let the fentanyl act, let the buprenorphine act, let the midazolam act. You are going to give only 0.5 milligram per kg of propofol, maximum in most of the elective cases. So if that is going to be there, your afterload reduction is not much. That is what we need to maintain there. Aorta load koranjichina, then the pressure is decreased, so the output may decrease. So propofol is needed less. So monitoring, she has already told major cases list she has told. So invasive monitoring TEE is only useful for assessing the vascular status. Central lines may be used for giving dobutamine and all these things. There is no relation between central line CVP and left ventricular end diastolic fiber length. That is the ultimate preload. That is the catapult theory. Fiber length is more, tuck. The contractility is more by Frank-Starling's law. So that is not going to say anything in the right atrium where we have put the central line. Urine output, temperature, ECG, yes, we have to monitor the rhythm. Allothane, nitrous oxide, ketamine have got doubtful diastolic impairment. Whenever we see, get the urine output is fine and see the dorsalis pedis pulse, many times we are a little safer in terms of cardiac output. So goal directed is optimal when there is, already I have told, backward symptoms are predominant. If that is not there, prefer IV fluids on the higher side. Multimodal analgesia everyone is doing, so it should be patient specific, because sometimes they may have mild renal damage, sometimes they may have other diseases, so you may have to avoid some ketorolac or something like that. It is multimodal, block with paracetamol, with buprogesic or whatever it is, but it should be patient specific. So that is the problem main. I have already told, somebody has told, intubation, extubation is a dangerous thing, Dr. Ekta madam. Coughing under the tube, that increases. Already we are not given proper IV fluids during the intraoperative period. We have done some masala. And the patient has coughed. Afterload is increasing. Patient is coughing. So sudden surge in the catecholamines. So everything puts up the patient into pulmonary edema. We have seen many of these diastolic failure patients after phenylephrine drops. Even in cataract surgery, they go into pulmonary edema. So diastolic failure, oxygen, CPAP, diuretics, other drugs may be continued. Dobutamine, levosimendan and melrinone. This levosimendan and melrinone have got lusitropy, what they call is chronotropy, inotropy, dromotropy and lusitropy. So lusitropy is positive myocardial relaxant effect. So that is what is the effect of melrinone. So we will go to the last slide. That's a good news for you. So preoperatively we are checking exercise tolerance and echo severity along with clinical signs. What are the drugs the patient is having? Sometimes be that other drugs may be having. One more minute is there. Investigations, comorbid conditions, and what is the surgery type. So if you have nerve blocks, then it is fine. Most of the problems are solved here. So, but what you have to maintain is rhythm, preload, heart rate, and avoid ischemia and hypertensive crisis. Rhythm, preload, heart rate, ischemia, hypertension. When you are going for GA, smooth induction and extubation, ready for oxygen, CPAP, lucitropic drugs. Multimodal analgesia, rule of 70, and already she has told no shivering because it may increase by 400% your oxygen consumption. Centineuraxius block, use it appropriately with less hemodynamic disturbance. Thank you very much for the patient hearing. Visit me at Pain Free Partha. Who knows, the diastolic limit may be the hit heroine in the next decade. Thank you very much.